Very good evening, everyone, and very warm welcome to IR Journal Club 360 Degree. It's my pleasure to welcome you, all of you, for today's session. This is our first session. IR Journal Club 360 Degree was started with a simple goal that our practice should go beyond the reading research papers and discussions. It's always important to apply the best available evidence in our day-to-day clinical practice, and this session will be designed to have encouraging discussions, thoughtful interactions, and sharing real world life experiences, so that everyone will learn from our great team of panel experts. Today's topic is the Woundosome concept, the shift in wound healing and intervention. Wound healing again is a very challenging, every one of us encountered in day-to-day clinical practice, especially managing patients with peripheral arterial disease, diabetic foot, venous ulcers, and chronic non-healing wounds. Although restoring blood flow is the very first step for essential for wound healing, we all know that it's much more beyond only revascularization. Now, this article introduces the new concept of understanding wound environment, encourages us to think beyond traditional concepts of having inline single flow to the wound. Our format today is very simple and interactive. We'll begin the session with article presentation by Dr. Antriksh. He is a renowned interventional radiologist practicing in various areas of Mumbai. This will be followed by relevant clinical case discussions. I'll be leading that case discussion session. We'll discuss multiple cases, and we'll have the opinion of experts. How do they manage cases in their day-to-day practice. We are fortunate to have experienced panels in today's session. We have Dr. Vimal sir, Dr. Girish sir, Dr. Anirudh Kulkarni sir, Dr. Bhavesh Popat sir, Dr. Virender Sharan sir, Dr. Ganesh Devkar sir, Dr. Linan D'Souza sir, Dr. Daksh Chandra, Dr. Karan, Dr. Antriksh, Dr. Shubham, Dr. Vaibhav Thakur, Dr. Nikhil Parotkar, and Dr. Chirag. Without delay, let's begin today's session. And it's my pleasure to invite Dr. Antriksh Vijan to present the landmark article. Over to you, Dr. Antriksh.
Can it be seen now?
Yeah, now the screen is visible. You can put the presentation on PowerPoint mode.
Very good evening to all of you present here today. Really medicine. Because this article itself is more of an editorial with some meta-analysis and the vascular expert shown. We are doing this journal club in the form with relevant, critically important points that we would be discussing in the form of first what the Woundosome concept is, as per the article, an anatomical and angiographic overview, the transition from the angiosomal concept to a more evolved definition of the woundosome. And by definition, the woundosome does imply that the blood flow must reach to the distalmost part of the wound, and hence the plantar arch does warrant a discussion when we're talking about this topic. So the article in point is the Woundosome concept and its impact on procedural outcomes in patients with chronic limb-threatening ischemia. This was published by Petrone et al. In 2024 in Journal of Endovascular Therapy, which is a relatively high impact factor journal. This was a multidisciplinary coalition that came together in the form of vascular experts and vascular and interventional radiologists, vascular surgeons, all of them together. And what exactly did they want to tell us? So, as per this article, the end point of revascularization, when one is attempting to revascularize, should be the wound supply as assessed on the wound blush or functional parameters. The angiosomal main artery revascularization is not the end of the road. what it says is use any and all possible means or all possible roads to get the blood to the wound, focusing not only on the main vessels, but the final common artery that will supply to the wound, which refers to the BTA interventions, not just below the knee arteries, but below the ankle vasculature warrants addressal. Target non-angiosomal arteries as well if needed, if that is the final pathway leading up to the wound in case of chronically occluded crural artery. In that case, even non-angiosomal revascularization will do the job and must be done. And third is harness collaterals or other collateral circulations to reach the wound in the form of whether using the largest collateral that God has given us, which is the plantar arch itself, or some smaller, uh, you know, uh, choke vessels, as they call it. So, choke vessel angioplasty in the form of a transcollateral angioplasty if needed. This article is cited in the article in question. So, this is a very old article from 2014 by Marco Manzi, but something worth reading and has been prefaced in the present article by Lorenzo Patrone, describing the vascular imaging of the foot as the first step in successful revascularization. This was the time when we started talking about below the knee arteries in detail. What is important for us to remember is that there are three anastomoses between the anterior and posterior circulation, and we will be looking at them in the next slides. But what is I'm just switching on my laser pointer here. Yeah. So what this tells us is that the anterior circulation, there are two vascular territories, okay, the great toe and the dorsum of the foot, supplied by the anterior tibial artery. These are the anterior pedal angiosomes or vascular territory supplied by a single major vessel. On the posterior or plantar aspect, we can see that great toe, yes, is usually supplied by the medial plantar artery via its deep branch. We will see the anastomosis in the next slide. And then there are three other angiosomes, which includes the medial calcaneal artery involving the heel and the lateral plantar artery involving the lateral aspect. So angiosomes refers to these units of myocutaneous tissue, that is muscle and skin, supplied by a specific arterial territory. The issue with this is it can have a lot of variations, with the peroneal taking supply in some cases, the PTA, ATA, mismatch in terms of what the traditional angiosome is represented. So those variants can occur. And second is there can be significant overlap in certain watershed or threshold regions. That's why it's not completely reliable. The same article by Marco Manzi as well as now by Lorenzo Patrone highlight the importance of a good lateral oblique. All of us doing vascular work do take a good lateral view of the foot. We make sure that we go ipsilateral oblique to view the plantar arch in detail. What is of importance here is make sure we go oblique enough that the fifth metatarsal bone is projecting out. So here you can see in the box. So the fifth metatarsal bone, its tail, should be seen projected outward from the base of the foot. When we do that, it makes sure that we achieve a good separation between the medial and the lateral plantar arteries. This will enable us to perform more successful plantar arch angioplasty. What is a little bit different and not many of us may be doing is doing an anteroposterior view, that is a true AP view. This is done when we take a contralateral oblique view. And of importance here is when we're asking to go oblique, the point at which you need to stop is when you see this intermetatarsal gap that is well seen. Once you do that in the AP projection, you're able to distinguish between the medial plantar and the lateral plantar artery and the dorsal plantar artery, like the dorsal branch coming out of the medial artery. So below the ankle anatomy, we know the anterior tibial artery continues as the dorsalis pedis. On the plantar aspect, you have the posterior tibial artery. Peroneal artery can sometimes have dominance. And there are at least three anastomotic communications between the anterior and posterior circulations. The first is the arcuate artery of the DPA, which anastomoses to the lateral tarsal artery. This supplies the superficial of the dorsum. What is of importance to us is the second and third one, usually in diabetic foot work, where medial plantar artery, which is a branch of the posterior tibial artery, anastomosis with the dorsal metatarsal artery, which is a branch of the DPA. This arcade supplies the great toe. Next is the lateral plantar artery, which is a branch of the posterior tibial artery again, anastomosis with the deep plantar branch of the DPA, forming the deep plantar arch or the pedal plantar loop, supplying the second to fifth toe. To better show this, we have some graphics with us. So here we can see the anterior tibial artery coming down and then continuing further as the dorsalis pedis artery. As it comes down, we have the deep plantar artery here, which is the anastomotic communication. When we talk about the posterior tibial artery, divides into the medial and the lateral plantar artery. And the lateral plantar artery, as we saw, comes in an anastomosis with the deep plantar branch of the anterior tibial artery over here. So this is the main pedal plantar loop. The second accessory anastomosis would be between the medial plantar artery and the first dorsal metatarsal artery. And the third one is going to be between the arcuate artery and the lateral tarsal artery. So just to show these on angiograms, here we have the dorsalis pedis artery. We have the medial plantar artery here coming out of the PTA, and we have the lateral plantar artery coming out here. And this is how they would anastomose. And that is the area of expected revascularization. Again, within AP view as well, we can very well demonstrate and predict what pathway should be taken for adequate revascularization. So with that background, what the Woundosome concept tells us is more of a conceptual and paradigm shift in terms of not just what territory a wound falls in, but does the actual wound bed receive perfusion at the end of your angioplasty, is what the Woundosome concept speaks about. Couple of things here that we need to look at. Yes, direct arterial inflow is very much a part of achieving the Woundosome. But whenever we need to, the choke vessels or interangiosomal pathways may need to be harnessed in the form of collateral circulation, with the plantar arch being the most important one. We must look at the inframalleolar networks that we've just seen and look at the microvasculature as well. So if we have to compare the angiosomal concept with the woundosome, angiosome is strictly speaking in terms of the anatomy, where tissue is looked at as a 3D structural block supplied by a source artery. So the goal is, if you see a wound in the territory of the dorsum, which is likely supplied by the ATA, go and open up the anterior tibial artery, is what traditional angiosomal concept would tell us. What the woundosome tell us is that if you have a wound on the dorsum, look at the best possible way to get blood flow up to this wound, whether that means the ATA, the DPA going to the plantar via the posterior tibial artery, or any other method, and confirm that this perfusion has been achieved to call it successful revascularization, is what the woundosome concept tells us. What this article also tells us is that in 1993, 15% of major amputation was found to be in the presence of patent femdistal bypass. What that means is successful surgical bypass, vascular bypass done for distal femoral disease. 15% cases showed major amputation despite good inflow. That is what led us to the concept of BTK interventions, and the angiosomal model theory came up here, saying that only inflow revascularization is not adequate, but specific vascular territory must be addressed. The cause of failure in these 15% cases on retrospective analysis was found to be plantar arch interruption, which means that even if one crural artery or one tibial artery was patent, but the plantar arch was interrupted, the wound healing was not adequate and patient underwent amputation. This data we have now got to know retrospectively. So this is the clinical relevance of the woundosome concept. The problem is we still have high rates of non-healing wounds and MALE, that is major adverse limb events, in patients with critical limb ischemia who have been said to have successful revascularization. What we are focusing on is to open the main artery. We are
Okay, by the time Dr. Antarish joins again, so we'll have some questions to our panelists. So I would like to ask our expert panelist that on table, what are your parameters for analyzing whether you have done the good job or not? So previously we used to have a single inline flow concept where we used to recanalize the straightforward single artery to the wound. But now in today's era, what are your different parameter for analysis which gives you satisfaction and which tells you that now the job is done and a patient will have good outcome eventually?
Suraj, you could, I think in the meanwhile, once Antariksh is joining, some network issue with him. Uh, do you want to start showing your cases so that we can have a discussion based on that?
Sure, sir. We'll start a case discussion as well. So we'll start with the case discussions. We have few interesting cases lined up. So starting with our first case. So this was a 56-year-old male with multiple comobs in the form of uncontrolled diabetes, CVA, CAD postplasty. Patient had multiple toes wound which was there since 4 months and patient was ignorant to those symptoms. On Doppler, infrapopliteal popliteal supramalleolar, that is ATA P10 peroneal, were showing biphasic flow. So on Doppler, we were pretty sure that this patient was having below ankle disease that was resected to plantar arch. So this was the picture on angiography where you can see anterior tibial arteries continuing as DPA. However, there is interruption or incomplete arch. On the posterior side, you can see posterior tibial arteries continuing up to the ankle. Both the arteries are very crisp till the ankle level. However, below the ankle, there is significant CTO in lateral and medial plantar arteries. So I want to ask panelists like how will you approach this case? What will be your approach and what things you will keep ready and how will you go forward for this case? So we have Dr. Linan sir, Dr. Dak sir, Dr. Karan sir, and Dr. Bhavesh sir right now, and we can have their experience from this case, how they can approach this case.
Yes, so Suraj, I think where is the wound? It's in the region of the great toe,
Yeah, so it's on multiple toes. So
multiple toes. Okay.
predominantly on the first and second.
So I think just to add, I think now we moved on more towards below the ankle angioplasty. So surely, I think we wouldn't stop and say that nothing is possible. I think we would try and revascularize both the loops probably. So I think in this case, probably the lateral plantar artery, go from the PT and try to revascularize the lateral plantar artery and then the pedal plantar loop for sure to improve the blood flow. There is enough data now showing that revascularizing the pedal plantar loop would help in wound healing. So uh, I think for sure, sir. I don't know if anyone else, Bhavesh, sir. I think this.
So yeah, I'm certain we do it regularly. I thought we can have opinions from others. Lennon, you do a lot of BTK disease and interventions as well. So what is your opinion? And in case if you have to do this, what's the kind of hardware that you would look at for the procedure?
Hi Bhavisa, hi Karan, hi everybody. So yeah, I think in this case, most of the time, what I try to do is, of course, I use a command 014 wire as my standard workhorse wire. So I would probably take a command 014 wire, get across the posterior tibial artery preferably, and try to revascularize the pedal plantar arch. In this case, you can see a few curves also in the posterior tibial artery. Sometimes what helps is if you can dorsiflex or plantarflex the ankle, sometimes that posterior tibial artery also straightens out a bit. So sort of try and straighten out that artery a bit and go from the posterior tibial artery. since that looks more diseased. As I'm getting through the pedal plantar arch, if in case with a regular balloon and a wire, I'm unable to cross, then sometimes a support catheter can be very useful. In my case, I use a Sargent from iVascular. Sometimes even a ProGrade microcatheter also is very helpful in crossing BTA across the arch. And yeah, and occasionally I also use Asahi wires also below the ankle to get across the pedal plantar arch. So I think that would be most of the time my go-to armamentarium
Yeah.
for this sort of a case.
Just to add in, how would anyone be comfortable? I agree that we would be starting with the posterior tibial artery only, but would anyone be comfortable going across the anterior tibial across the dorsalis? There's a single patient. How comfortable would let us assume that obviously that we are not able to get across the lateral plantar artery from the PTA territory. How comfortable or what would be a threshold of opening the pedal plantar loop through the dorsalis pedis artery? Let's say that the PT access has failed. Would you still be aggressive in opening the pedal plantar loop, or would you leave along and say that there is good flow up to the ankle level at least with the patent dorsalis and leave it alone?
No, I think in this case where there's gangrene to multiple toes,
Hmm.
if in case the lateral plantar is failing, then
Hmm.
of course we would go through the dorsalis pedis and try to
Dorsalis.
cross it. Yeah. I
Right.
think
Right.
I will give the best shot possible, but if it's
Hmm.
not happening, you have to go from the other side. I think in this case with multiple toe gangrene, the way
Hmm.
the foot is looking, I think you have to complete the arch.
So basically being aggressive, I think that is, I mean,
Absolutely.
open up the loop as much as possible. Okay.
Absolutely.
Okay.
So, sir, any role of support catheters, because since we are operating in below ankle area and coming from the femoral, still you have a long distance to cover. So, do you prefer to keep long sheath in popliteal, or you just go with headhunter?
I use a long sheath for all cases. So I use a Ansel sheath from Cook, a 45 centimeter sheath, which reaches up to the knee joint in most Indian individuals. And through that, of course, balloon and wire or a support catheter. In my case, I told you I use a Sargent support catheter because it's available in an angle tip, and sometimes it's useful to have a slight angulation, which helps me direct my wire accordingly. Because sometimes you don't get 1:1 torque on all wires, along on all O14 wires so easily. So sometimes an angle in the catheter helps, and occasionally I've even used a ProGrade. So I found sometimes that when I fail a lot or it's not crossing, sometimes a ProGrade really helps me cross. So I always have a ProGrade also handy to try and cross these vessels. Bhavesh, sir, do you have any inputs on this?
So somehow uh, I have a comfort not using long sheets in all my cases. So we never use long sheets at all. And especially when you're dealing with a BT below ankle lesions, my comfort is most of the times balloon and the wire. And our first go-to wire is a Fielder FC wire, because a lot of times these posterior artery, as you mentioned, have this tortuosities and turns. We feel more than the crossing. It's the way the wire moves is important. So we use quite a lot of balloons and Fielder FCs. And in case if at all we have to use support, then our comfort zone is again headhunter and a prograde, or very calcified lesion. Then we have these Asahi Armet calcified support catheters we use, but that's in extremely rare cases where we have very calcified vessels. Otherwise, most of the times you would prefer using a Fielder FC and a balloon, or a headhunter and a prograde to support it.
Yes, sir. And sir, any opinion regarding the sizes of balloons? So below ankle, what size of balloon you prefer?
I generally prefer a 2 balloon
Okay.
for the pedal plantar arch. I generally don't oversize beyond 2 unless, of course, it appears to have a visible mismatch. Otherwise, generally at the level of ankle, it's 2 millimeters for most Indian patients.
Yeah.
Okay. Okay. So let's see what we have done in this case. So going forward into the case. So this was the very beautiful demonstration of anastomosis. Just to re-emphasize what Dr. Antriksh has told. So there is anastomosis between the medial plantar artery and the first dorsal metatarsal branch of DPA, which applies to the great toe. So a second anastomosis is between the lateral plantar artery to the deep plantar branch of DPA. Again, that supplies from second to the fifth toe. And there is again superficial dorsum anastomosis, which is between the arcuate artery of the DPA and the lateral tarsal branch of DPA. So in this case, we decided to go ahead with the lateral plantar archplasty. So we crossed the lesion with Fielder FC and balloon. So 2 by 150 was the balloon size which was used. So we were able to get up to the base of the metatarsals, and after the plasty, there was still area which was not getting good supply. So we again decided to come from the DPA side and do plasty from DPA branch. So this was the end result, where you can see there is good reformation of the plantar arch, but there are few still areas of stenosis. However, we can't say whether this is a interrupted or arch or this is a complete arch. So in our case, where patient was having ischemia of all the five toes, important thing here is to revascularize as much as plantar arch as possible. And in this case, we did came from both the sides, from lateral plantar and DPA, and did as much recanalization as possible. So this was how AP view is very essential to demonstrate Woundosome blush. So this is again, practice has changed now. We are doing AP views as a last run for all our cases, which again gives confidence to say to clinicians and patients that now we have a good supply to the wound. And again, we can send these images to clinicians, and again we can convince the clinician and patients also that you have the good supply to the wound, and this patient will improve eventually. So in this case also, you can see there is good blush to the second and first and second toe, which was correlating with our clinical picture. So a follow-up of this case, you can see there was a wound which was predominantly on the first and second toe. Post PTA plasty, you can see good granulation tissue and good blood flow to the wound. And eventually, over the following subsequent months, patient did well with the good wound healing. So coming to case two, this was a 62-year-old male, case of CLTI. Here the wound was only on the great toe, which was not healing, with changes of gangrene in the form of blackening. Again, this patient was posted for PAG and revascularization. So this was the picture on angiogram. You can see there was a good inline flow to the great toe in the form of ATA, DPA, and metatarsals. So, according to our old concept of angiosome, the great toe wound should have a patent ATA, and we should do plasty of ATA. According to that concept, now the ATA is in this patient is already open and it's already healthy. Still, the patient is having gangrenous changes on great toe. So now again here I would like to ask panelists, how would you approach this case, since this patient has a good inline flow in the patient with a wound on great toe.
So can we ask? I think Anirudh sir is joined and Daksh is also there. I think they can give their inputs. How do they approach their cases like this?
Hello, can you hear me?
Yes, sir,
Yes,
very
sir.
much.
I'm actually in transit, so that's why my video is shut off. I'm on the roads. So very very well presented, and very important point being highlighted here. In couple of years back, we would not have we would have thought that it will be a futile exercise, but we should try and open the PTA in this patient for sure.
So, sir,
Because
what
in
would be
fact,
your go-to hardware for something like this when you have a bad long segment occlusion here?
it is like I would generally want to take my base guiding catheter up to the origin of the artery, and we literally will have to dig here with a micro catheter, or directly go with a balloon. Some or sometimes, Bhavesh, we have even used a Terumo wire to create a channel and then got in
Yes.
our micro hardware. So these are very unpredictable, and sometimes even a 014 wire might just easily glide in across what looks like a very formidable lesion. So sometimes very small focal lesions, where we feel that the angioplasty should be over in the next 5 minutes or 10 minutes, we struggle to cross and we struggle to take the balloon across. And sometimes even such long lesions which look very formidable, the wire would just walk in. The other option is to try and, if we fail from the anti-grid approach, one can try across the pedal arch to get from the ATA into the PTA. That may be one of the things that we can try here.
Okay, I think Suraj, you can carry on.
Yes, sir. So, different approaches as mentioned by Anirudh sir. So again, based on angiosome concept, this patient already have a single inline flow to the great toe. But now
Okay.
again, with the new
आवाज बंद करो.
Woundosome concept coming, we have two options: either come from lateral plantar artery and revascularize the plantar arch loop. The second option being open up the medial plantar artery again, which has an anastomosis with a collateral from first dorsal metatarsal artery. So in this case, we tried to recanalize from the medial plantar artery. So the crossing was easy. It was done using again Fielder FC wire with supported by the 2 by 150 balloon. So with that hardware, we could able to cross from the medial plantar side to the first dorsal metatarsal artery again, which is a branch of DPA. So you can see how beautifully balloon has tracked. Now with this, now you can see pre-plasty, you can see there are two branches from the PTA, so lateral plantar and medial plantar. But in this case, we try to go from the medial plantar side and did the revascularization of the till the dorsal metatarsal artery. And this is how on the AP image you can see good woundosome, good blush to the first toe. Again here, woundosome concept coming into the play, which again gives us confidence that we have now good blush to the wound on the first great toe, and because of which now we will be confident that this patient will respond to our therapy. So this is how the clinical follow-up of the images. We can see on post-procedure, post-amputation of great toe, there is good blood flow to the wound base, and this patient eventually did well with amputation. So case three, again, this is again very interesting case. 54-year-old female, diabetic, right lower limb CTLI. This patient had ulcer on the heel area, which is again according to angiosome concept, it's in PTA territory. So on color Doppler, there was BTK disease. Hence the patient was planned for PAG and PAG SOS plasty. So this is the picture on angiography. Now you can see there is a ATS stump which is there. However, on PTA side there is a focal short tight stenosis on the PTA origin, and again there is a long segment occlusion on both sides, ATA and PTA. In the foot area, run of images, we can see there is good reformation of ATA and PTA. So again, I would like to ask panelist Daksar Linan sir, how would be your approach, and which artery you will choose first? This patient has ulcer on the heel area.
I think with the heel ulcer, of course, posterior tibial artery has to be our artery of choice. So probably go and try attempting revascularization of posterior tibial artery, and then try to complete the arch since distal dorsalis pedis is visualized. In this case, try to try to cross it, intimately. But if not possible, at least try and pass a loop of wire. And sometimes pushing the loop helps get across these long CTOs quite well. So try and form a loop of a small command wire there and push the loop forward along with a balloon. Sometimes helps to cross the CTOs quite easily. Daksh, what do you think?
Daksh, are you around?
Okay. So as said by Linan sir, again the wound was in heel area. we first tried to revascularize the PTA. So in this case, again, PTA was our first choice. The second option can be ATA if you are planning for indirect angiosum, but of course the PTA should be the first option to go for this case. So, but for this case, there was a proximal PTA tight stenocalcific lesion, because of which there was wire was not going across the origin. So uh, with this picture, PTA origin is not able to cannulate and wire is not crossing. So what should be the next step in this case?
So, Suraj, what was the distal outflow? Probably a retrograde access is one option, I think.
Yeah, so distally, there is good reformation of both AT and PTA.
So I think one option is that because the lateral plantar artery and PTA seen a retrograde option in the, obviously I would start antegrade only, probably from the proximal ATA PTA. But if not, then a retrograde PTA access is one option to cannulate the PTA. That is one option.
Okay, so you mean to say that you will now try for ATA plus and then try to go across the arch loop?
Either one option is to take a retrograde PTA access. Otherwise, at least recanalize the ATA antegrade if that is going on. So one of the two arteries, but a retrograde PTA access is possible in this at the level of the heel. There is some reformation there, so probably a retro access there.
Yeah, yeah. So again, a new technique, retrograde access. So can I ask Karan sir to elaborate more on how to take retrograde access in such kind of scenarios?
So I think I would take. Am I audible? Sorry, I'm in a note. Am I
Yes, yes,
audible? Yeah.
yes.
So probably to get a good ultrasound, I'm sure the PTA would be seen. You would see some flow on that. On ultrasound, I would take probably using a micropuncture set and a V18, a direct access into the PTA. Use a V18 through the micropuncture needle, and then park the microsheet through that, and use a prograde again and try to cross retrograde from the PTA. Ultrasound is a game changer. So I think on ultrasound you will be able to see the artery and you will be able to make sure that you're in the lumen.
Okay. So in this case also, since there was a tight stenocalcific narrowing at PTA origin,
Hmm.
so we decided to go ahead with the ATA plasty and then do
Yeah.
indirect revascularization if possible.
Hmm.
So we crossed the PTA tandem lesions and did the plasty with 2.5 by 220 balloon. After that, there was complete recoil of ATA. So now PTA is, we are not able to cross the PTA origin and it is having complete recoil even after plasty. So what should be the next approach then?
So I think if retrograde PTA access has been taken and even if retro is filled, probably again try from the ATA and see where is the level of recoil.
Okay. So for this case also, so since there was a complete recoil, we did a long lasting balloon plasty. So 5 low pressure, 5 minute long lasting balloon plasty was done. Even after that also there was persistent recoil. So we had another option in the mind. The pedoplantar loop technique can be utilized for this case. The second option was also there to have a retrograde PTA access and do the PTA plasty across the origin. So for this case, we opted for the transplanter root technique. So we cross the plantar arch using fielder FC and balloon 2 by 150 balloon. Again, this was the crossing s- which was done across the plantar arch. Again, here the pertinent point is that you need to have true lumen to true lumen entry across the PTA origin, or else you will create a dissection flap and you will have the acute shutdown of entire PTA. So this is how the wire was taken across from the ATA across the plantar arch into the PTA and try to negotiate across the PTA origin into the TP trunk. So again here PTA lesion was able to cross with the wire from the retrograde axis. However, due to there was long length for balloon to travel and balloon did not cross the proximal PTA lesion. So in this case, what should be the next choice of hardware or what should be the next strategy?
I think like Anirudh sir said, I think one option is to directly poke it with a Teremo or something, again antigrade. I don't know if that was tried in this case. Again, try antigrades with the PTA or something like that. So
Yeah. So here, since balloon has a long pathway to travel, we did have multiple options on the choice. So again, snaring of wire. So we have one end of wire going from the sheath, and other end distal tip was into the TP trunk. So it was one option that to put the snare or catch the tip of wire into the headhunter and uh, try to do balloon body flossing technique. Another option was that since the support was lacking, we could have switched to the long sheet into the popliteal artery, which will give good support across the arch through which the balloon will travel easily. Here also, because of multiple lesions inside the arch, there was gripping of the balloon at the pedoplantar loop level, for which because of which the balloon was not getting travel across the PT origin. So we did balloon plasty of the plantar arch region and the PTA, distal PTA, all the tandem lesions. And we thought that since balloon was getting grip because of all these lesions, after the plasty, balloon will travel across the PTA origin. But even after that, balloon was not getting crossed from the retrograde axis across the PTA origin, and we were again back to the level one from where we have started. So now, in this challenging case, almost 2 to 3 hours down the line, now what should be the next step, and how will you approach this case now?
So, so Suraj, the thing is, even in your first angiogram, the PT is not completely occluded. It's highly stenotic. So I would honestly take a prograde and try to cross it using a prograde microcatheter,
Okay.
and we should be able to cross antigrade the posterior tibial artery. If we're able to
Okay.
get across the posterior tibial artery to begin with, then a simple angioplasty of that should open up the entire segment. Especially now that you have already completed an angioplasty all the way across the loop.
Kumaru MP.
Yeah, yeah. So again, that was also one option. So we did peroneal and TP trunk plasty across the PTA origin. We thought that there was stenosis at the TP trunk, which was not able to able to cross our wire into the PTA origin. So after plasty, this was the picture. Now you can see there is slight kind remodeling of the plaque which was there at the PTA origin. After this TP tongue and peroneal plasty, we were able to cross our balloon and wire from the above side, so from the antegrade axis. So the reason for easy crossing of PT ostium from antegrade approach was that there was a already we had cross wire from the retrograde transplanter approach, and which has made our pathway so that now the new antegrade approach wire has crossed across PT origin. The second theory was that post TP plasty there was plaque shift, because of which now our wire and balloon is able to cross across the PT origin. So after this, the job was quite easy. So after crossing the PTA from the antigrade approach, PTA plasty was done using 2.5 mm balloon, and this was the final run where you can see there is good reformation of the lateral plantar artery, and the wound was on the heel area where you can see wound blush. So this was again a challenging case, again pertaining to Woundosome concepts, which tells us that at the end picture, if you get the blush around the wound area, you will have the good outcome eventually.
just to ask all the panelists in this case, because the proximal PTA was so calcific, would anyone be comfortable placing a stent here at the proximal PTA because it was such a tight lesion?
Probably not.
So I think our experience is contrary to that. When you're looking at one single major vessel, which is an important vessel for the foot, and if you have a origin involved, then probably at the origin we don't shy away from putting a coronary stent. It has given good results over a period of time. So single vessel runoffs largely, which are important ones, origin we don't shy away from putting a stent.
So have you tried the bioabsorbable stents on metal in these
No,
cases?
the problem with bioabsorbable stents is that they tend to recoil a lot. So to open up a bioabsorbable stent of the size of 2.5 mm, you'll have to do a balloon of 3 to 3.5 mm to create a bed for that. So that somehow we were not comfortable, and the stents generally does well. The coronary stents do very well.
Okay, good.
So, any panelist have experience on using pedal acceleration time as a marker for wound healing?
So not yet, but I think this is something that we want to incorporate into our practice now. So thus far we were relying on good angiographic images, especially the lateral oblique and the AP views. But I think now PAT will be something that we'll incorporate into our practice regularly. What about you all?
So we've been using PAT frequently, but the problem is the acquisition on Doppler and the imaging that we're getting is a little skewed. So I think with respect to the ultrasound machine and the Doppler that we're doing, I think that is where we are not getting accurate values of PAT.
Okay. Uh, apart from this, sir, what are the challenges you see in this Woundosome concept? Since with the Woundosome now we are trying to uh, put some objective criteria for wound healing, but even in the wound blush there is kind of subjectivity. Some people might feel that it's not a good blush, and some people will thought that it's a good blush for healing. So again, I think we need to have some kind of grades or kind of scales in the Woundosome blush, which will again add some remove the subjectivity and will give good objective criteria for wound healing.
I think the article mentions that, no? So they mention about checking the tissue oxygenation and tissue perfusion. That is some micro
Yeah.
oxygen sensors, that diffusion speckle contrast analysis. Because we won't be able to quantify it. Ultimately, with the Woundosome, it is ultimately visual. But if you have those micro oxygen sensors or diffuse speckle contrast analysis or perfusion angiography, or PAT for that matter. These may be more, better techniques to assess wound perfusion. We don't have all of this, but I think once we start using the PAT into our practice, this is something that we can keep at as a ready reckoner for us to understand how the perfusion.
Yes, yes, very important point highlighted. Again, I want to ask Dr. Karan sir, what is your experience with the perfusion maps which we get with few machine software? So again, that is one of the objective criteria to assess the wound healing.
Sorry. So perfusion maps I mean, we are getting good values of acceleration time as well as area under the curve. I think these two are the good markers as per literature that gives a good objective criteria telling the clinician then that the blood flow is improved. So we are using that routinely. The problem is that it is not available on all the machines. That is one thing. Second thing is we are combining not just the perfusion maps, but like I said, we are using PAT as well as a marker, and along with that, we're also using proper blush pictures. Once we have a post plasty and we're looking at good blush, we are quite confident that this is going to improve wound healing, and along with the TCPO2, which we are adding pre and post procedure. But out of the perfusion, we are using area under the curve. That's a great marker, as well as the acceleration time. These two are good markers on your perfusion maps depicting wound healing or prognostication, basically.
Okay. Now, as uh, pertinently said by Dr. Karan, now we have Dr. Antariksh who has joined now. There was some network issue from his side, but there are few key takeaways from his presentation, and we would like to end our session with his key takeaways. So, I will hand over the session to Dr. Antariksh.
Right. Uh, Hopefully, I'm audible now, Dr. Suraj.
Yes, yes, you're audible.
Can you hear me, Dr. Suraj?
Yes, Dr. Nish, you're audible.
Okay, great. I'm just sharing my screen. So, when people talk about AI taking over, I think we are very far from that situation, given that in today's day and age, still we face these technological glitches. So, I think we are safe on that front at least. Having said that, just quickly sharing my screen. Is the screen visible now?
Yes, the screen is visible.
Okay, so I know we're short on time, so I'm just quickly going to show few crisp slides that are going to convey what we really need to know on this article. Basically, the Woundosome concept was described by Lorenzo Petrone et al. In 2024 in Journal of Endovascular Therapy for the first time, which is a relatively high impact factor journal. This was a multidisciplinary cohort of experts ranging from IRs, that's vascular intervention radiologists, vascular surgeons, as well as cardiologists who came together to describe this. To simply put it, what it tells us is that the end point of revascularization so far, wound supply is what we are looking at, which we assess, like we just discussed. Lennon sir just spoke about the wound blush, or the blood flow to the wound on the angiogram. By using the wound blush as an endpoint, the angiosomal main artery, that is opening the ATA for a wound over the dorsum or opening the PTA for a heel wound, is not the end of the road. Use any and all possible methods to get blood to the wound bed, is what they've tried to tell us, focusing not only on the inflow, the crural arteries, but also the BTA arteries. So below the ankle arteries must also be addressed as the final common pathway leading up to the wound. If your angiosomal artery is chronically occluded, that's not the end of the story. Use a non angiosomal artery and maybe reconstruct another collateral, such as the plantar arch, which is the largest collateral available to us, and get the blood flowing into the wound bed, either angiosomally, non angiosomally, or through collaterals, is what they've tried to tell us. Marco Manzi came up with this article in 2014. This is cited by the Petrone et al. Team, and that tells us about all the views. Not going to go into all of that, and I'm going to skip directly to what we were just discussing, which is the functional endpoints. So, just allow me a moment. Yeah. So I think this distinction is what is important to us, that angiosome is actually an anatomy based concept where a myocutaneous structural block is what we are looking to revascularize. That is a muscle and skin tissue supplied by, say, ATA, PTA, or one of their branches. It is, if there's a wound in this area, open that artery. If it can be opened, open it. If you cannot open it, well, that is what the angiosome is based on. What woundosome tells us is the actual perfusion to the wound bed is what matters. Wound blush is one way to assess it, and other ways to assess it are in the form of various perfusion parameters. So I'm just going to show that slide about the perfusion parameters so that we have some clarity on that. So tools for functional perfusion assessment must be utilized to confirm woundosomal revascularization. PAT by Jill Somerset, we've just discussed. Dr. Karan and Lennon sir was just talking about that. So the issue that we face with that is the standardization, machine to machine variation, looking at the settings. So maybe having a hockey stick probe and doing it with that might be a better call, but that is labor intensive as well. I mean, if you're leading a busy private practice, it becomes challenging to do, but we make it a point to map out the pedal acceleration time whenever possible. We've started incorporating this into our practice heavily because it seems doable. TCPO2. So any of us who are working with diabetic foot surgeons know that TCPO2 is something they definitely map out at their clinics, and that really does predict wound healing. The two new things, what sir was also just talking about, is skin perfusion pressure and ICG angiography. So we don't know the practical implications of this and how far we can incorporate this into our practice. But the first two, that is the PAT and the TCPO2, is something that definitely warrants consideration. Two other things that they've spoken about in this article is that as per Woundosome, the primary aim is not just do one of the tibials and get done with it. What they want us to do is look at the outflow arteries, directly visualize them. So that means taking maybe a biaxial or a triaxial system. Am I audible still? Just confirming because I got cut off the last time. So I hope I'm
Yes,
audible.
yes.
Okay. So take an antegrade femoral axis, use a biaxial or a triaxial system, place your catheter at a safe location. So even just suprapopliteal or just infrapopliteal is what they've also described in this test. In our practice, we usually keep our guiding or a diagnostic catheter just above the bifurcation or trifurcation and take a DSA. What this does is it maps out any collaterals, any hibernating vessels, and can give you an idea whether collateral plasty is possible or not, or plantar arch plasty is possible or not. So this is something that is a good takeaway for those of us who are not doing vascular cases very routinely. For them, this is useful. Take multiple projections. So like we just discussed, the lateral projection, we all do that, but the AP projection, so we've now incorporated that into our practice heavily. We always end our DSA with an AP projection of the foot to demonstrate the flow. And so they also talk about looking at the max score, that is the medial arterial calcification. While the score itself is, we are all familiar with it in vascular medicine, having a high max score does tell us or prognosticate that the angioplasty may or may not be, as successful as one would want. With that, just one word about the plantar arch plasty. These are small tortuous vessels. So while yes, as per the Woundosome concept, plantar arch revascularization is an integral cornerstone to achieving good outcomes in critical limb ischemia. But these arteries come with a pinch of salt. They are small, tortuous. They have a lot of side branches and can have a lot of calcium in them. So one must be gentle because spasm is known to occur, perforation is known to occur, there can be plaque shifts. So for the plantar arch, if you break, you do pay. So, one must be careful about that. And for that, just wanted to share some tips and tricks from our side, that once at the level of the ankle, we usually take a liberal, contrast loaded roadmap here to see the anatomy. Some hibernating channels may get demonstrated. Give a good shape to your wire tip. Use a soft tip wire such as Fielder FC, XT, or Regalia, and or the ProGrade wire as well. If there is a tough calcium cap, we switch to a support wire like a Command sometimes, or a V14 to break the cap, and then switch back to your softer wire. Do not push. Sliding or drilling movements are warranted when dealing with the plantar vessels. Stay luminal. So of course, the crural or the tibial arteries, we go subintimal all the time, and we have very good outcomes with those. But for the plantar, we make sure we're luminal. Use vasodilators when needed, and do not overdilate. A low prolonged balloon dilatation is what we perform. Just showing an example of plantar arch plasty for a heel wound. So with that, in terms of the article, what they've tried to tell us is, yes, direct arterial supply is not to be replaced. It is a part of the Woundosome concept. So angiosomal revascularization, if possible, and reaches to the wound, is a part of the Woundosome. But when it is not possible, indirect supply through collateral pathways, plantar arch revascularization, and dealing with the anatomical variations to make sure that overall there is good perfusion reaching up to the wound, is what they say. So the debate, so I remember talking to Bhavesh sir once, and sir said ki uh, hum to kar hi rahe the ye, to put it informally, like this is what we've been doing. Like the end point always has been that the wound blast should be seen on the angiogram. What we think is that this article just formalizes that concept, puts a name of woundosome to it, and in future studies or trials, the end point of successful revascularization should be decided not just on opening a tibial artery or doing a successful balloon dilatation of one or two of the crural vessels, but success should be defined as the blood flow actually reaching the wound in terms of the angiographic blush, as well as functional parameters, because the recent trials of best CLI and Basel 2, all of them do not give much attention to the BTA interventions. That may be a result why peripheral angioplasty may not be getting the importance that it does need to have. And the success of wound healing despite a successful revascularization might be a little bit lower than one would like. So maybe looking at an optimal endpoint is what is the biggest takeaway from the concept of woundosome, that look at the actual functional flow to the wound in the form of wound blush and other functional parameters. Thank you.
Thank you, Dr. Antrish, for that wonderful talk and introducing us to the very thought-provoking concept of Woundosome. So, as we come to the end of today's session, I would like to thank our speaker, Dr. Antrish. Then my sincere gratitude to our respected panelists, because of which we had a
Yeah.
valuable, insightful discussions.
Suraj, this side, Dr. Virender. Before you end, can I add few points?
Yes, sir. Yes, sir. Yes, sir.
Yeah. So, I mean, I joined a little late, but what I could make out is, see, those who are listening should take away few of the finer points. The thing is, now they have heard that some of the operators are just using a short sheath. Some are taking a guiding catheter. Then you spoke about filter XC. The other guy said about command. So I think the take-home message should be any wire which works in your hand is a good wire, but choose among the best available on the market. It could be Regalia, Command, Fielder XC, and then take your access, whatever your plan is. For example, in a case you were talking about snaring a wire, and then if you're taking a Fielder XC, which is a 180 wire and not a 300, then it becomes again a challenging. So these are few things you should, before starting a case. I mean, you can do a case with just a 4 French sheet. You can take a long sheet, maybe a 4 French, 5 French, 6 French, but you should have a good flush going on. Park it in the popliteal, not a problem. If somebody wants to take a terumo, that's okay, or a guiding, but keep it simple. The second thing which is not highlighted in the talk is please save radiation. If you're working 2.5 hours doing a pedal, it makes no sense because you have to work throughout your life. Okay, so you have to be very meticulous when to give way. If the ATA plasty is not working, it's recoiling, let go. Take a pedal access as current told. You have an ultrasound, the wire will go up. So see, whatever the Western guys tell you, most of the time their arteries are bigger than us. So try to remember. I mean, 2.5 hours would be too much if you spend doing a lot of BTKs, and there is a radiation involved. So keep it simple. Even just a 4 French sheath sometimes, and taking your wire works. Sometimes the case could be difficult, and if it is difficult, you have to basically keep all the backups. So you can take Armamet, you can take Sargent, you can take a balloon, doesn't matter. But plan it very, I would say, before your procedure, that you will spend this much time. And if this does not work, 5-10 minutes, just shift to the another way. That's what I mean. I thought I'll tell. There are like 33, 34 participants, and everybody might not be doing it very regularly.
Yes, sir. Thank you, sir, for those practical tips and key takeaways. So those are very important to end our session.
Yeah. And Suraj, one more
Yes, sir.
thing, just
Yes,
like
sir.
so theoretically we talk about PAT, we talk about we finish our case with anterior view, and we take a DSA. These are all fine, because I don't know how many of you do all your wound dressing. So we do everything. So it's not just your blood supply that heals the wound. Try to remember that, and that will make you stop whenever you cross a certain time limit and a radiation. You might be having the best of the blood supply, but there could be a lot of stuff, right, from infection, collection, joint involvement, a patient with a CKD on lemurs. So there are multiple factors that will limit your wound healing. So try to remember also that. So everything you have discussed is great. We can have an objective end, But ultimately, my take home as a practical to the students would be, do your best within that specified time. Go with ATA, PTA, peroneal ASAP. And even if you don't demonstrate, if you have a good run, that's good enough. So try to save run. Hardly I remember I do a DSA for foot. But if you want to do, that's okay, because if someone is not doing your wound work and you're referring the patient has been referred to you, and if you want to, that's fine. But again, in the long term, I'm telling, if you're working on a BTK work day and night, then you should learn to use a lot of ultrasounds and as low as radiation as possible. Thank you.
Thank you, sir, for those practical insights. With that, I would like to thank all our respected panelists as well for their sharing valuable insights, practical experience, and perspectives, which made today's sessions very enriched and fruitful. Again, I would like to thank all our participants for your active engagement. To conclude the session, I would like to thank Mumbai Vascular Foundation for creating this wonderful platform which brings the experts and learners across our entire country. So thank you once again for joining, and we look forward to welcome you to the next session of IR Journal Club again, where we'll come with new hot topic, hot discussions, and we'll try to dissect and incorporate all those concepts in our real world scenarios. Thank you, everyone.
Thank you, guys.
Thank you.
Thanks, Suraj. Thank you so much.
Thanks.
Thank you, sir.
Thank you.